I'm going to be going first in our EM Controversies lecture series for this. It's based on the renal topic that we have for the week. The case that we're going to be talking about involves a patient with uremic acidosis. I'll go into the details of that in just a second. And specifically the question of whether a bicarb infusion would be indicated or useful for this patient. So I want to thank the entire EMCCM team, or the entire EM Controversies team, as well as Dr. Surya, who will be arguing the counterpoint to my. All right. So, what are the objectives that we're going to talk about on my side of this? Is one, why should we care about whether we need to start this or not? Obviously, one of the things we can do for a person who's in uremic acidosis, who has renal failure, is give them dialysis. But I'm going to talk to you about why maybe we want to consider some alternative therapies and why that might be bad. Next, we're going to talk about why is even giving bicarb a thing, right? It's going to be important to understand that concept and its utility and role in the patient we'll talk about. And then we're also going to talk about specifically why should I consider this bicarb infusion for this patient. So I'll present the case. This is a 55-year-old male who has a past medical history of hypertension, diabetes, CKD4. He usually follows with a nephrologist as well as his primary care doctor. It's usually up to date with everything. However, this crazy thing happened called COVID, which disrupted a significant portion of this patient's outpatient care. And he was essentially lost to follow-up for about 4 months ago. And now he's presenting to your emergency department with generalized weakness and nausea, no specific vomiting, as well as he's a little bit somnolent. So his initial vital signs are heart rate of 90, blood pressure 170 over 105, a little bit tachypnic at 26, satting well otherwise. His exam is notable for the fact that he is somnolent but easily arousable. So not obtunded, is able to respond to you, answer questions, but prefers to be asleep more than just sitting up awake. Also important on the physical exam findings they told us is that he's not any signs of fluid overload. So you think this patient's euvolemic, you don't think he's necessarily dry either. We think fluid status is appropriate for this person. An EKG is also performed which shows no EKG changes consistent with hyperkalemia or any specific electrolyte abnormalities from that. No changes in the QT, no ischemia. And we're also given some information on the patient's acid-base status, but not all of it. We are given that the patient's pH is 7.1. The PCO2 is 30. The bicarb is 11. Sodium is 140. And potassium is 6.3. So we don't have a specific way to calculate entirely whether there's an anion gap or not. But we do also know that the patient also has a creatinine of 9 with a baseline of 4 that was 6 months prior before all this COVID happened. So a couple things that are important with this patient. One, he was hyperkalemic, but we do know that this person was treated appropriately in the emergency department for some hyperkalemia with treatment options, and we assume that that has improved a little bit. We're not going to focus specifically on the hyperkalemia part, we're just going to focus on the acidosis part. And we also do know that this patient's creatinine is now 9. From 4 of the baseline before, and the 4 was consistent with his CKD from before, and he does still make a little bit of urine. So now that we have a picture of the patient that we're talking about, I'm going to talk to you about why we should even care about doing it. So specifically, you presented this case, you gave the hyperkalemia cocktail, all of that seems to resolve. You call nephrology, nephrology says, yes, we do want to dialyze this patient, but let's not do it right now. Let's start this patient on a bicarb drip. And we'll come and evaluate the patient in the morning and see whether it gets dialysis or not. We can start it then, and we can place the shot at that. So I'm going to talk to you about why we should even care about this concept. So obviously renal failure, 1 in the chronic stages or 2 in the acute stage, is associated with very high mortality, significant morbidity, and requires a lot of resource utilization. And we have come to routinely do this, and we see a lot of renal failure in our patients here at Queens County and downstate. And, it's almost becomes kind of second nature. Oh, we'll call nephrology, we get dialysis, start doing sort of stuff. So obviously, that's still is a big burden on the healthcare system and for the patient itself. So obviously, right, we talk about resource utilization, we talk about why it matters. This is kind of the end goal for this person. We already know he's CKD4, he's maybe not that far off from dialysis, but does he need to be starting dialysis right now? That's kind of one of the main questions that we'll talk about. And the other thing is, what if we can just buy us time? So we'll talk about why this infusion of Bicarb might actually be beneficial to the resource utilization and morbidity of this patient. And we'll talk about kind of how we got there to why even this Bicarb concept is a thing. So why is it a thing? So obviously we know our different forms of bicarb. We have intravenous bicarb, we have the hypertonic solution, which is 8.4% bicarb, we have oral bicarbonate, which is almost essentially baking soda in the pill form. And we know that patients with renal failure are on this a lot. You might often be asked by nephrology to initiate it, sometimes in severe cases of acidosis with pH less than 6.9, people will start bicarb, depending on, even if it's not solely a non-NA-GAP acidosis, even in some of the high NA-GAP acidosis states. But the evidence behind this is kind of interesting, and that's kind of what makes this in the end controversial aspect. So why is it a thing? Nephrologists love bicarb, right? They're going to talk to you about giving bicarb to all these patients with renal failure, and obviously not all patients, not all, but most and a good amount of them. And why is bicarb even indicated? There are some situations in which bicarb is certainly indicated. Right? We know if you have a primary GI loss that causes a loss of bicarb, and that's your main etiology of non-NA-GAP acidosis, your bicarb deficit, you can replace it. And as long as you resolve the etiology that's causing the bicarb loss, you've supported that patient appropriately. Renal tubular acidoses are specifically associated with non-NA-GAP acidosis that if you replace bicarb appropriately and try to resolve the underlying problem, you'll fix the problem. So bicarb does have a role in this. So what about our patients with CKD and chronic kidney disease? So one of the important aspects of this case is this guy has CKD, and he presumably was stable, doing okay, on his medications, but lost to outpatient care, and is no longer possibly receiving the appropriate medications that he needs to maintain his current state of renal failure. So it's reasonable to assume that this person was likely on oral bicarb to begin with, right? His bicarb was probably titrated to improve his acid-base status, and we know from significant amount of studies, although the data is not amazing, there are some studies that have shown increased mortality or decreased mortality with utilization of oral bicarb in patients with CKD, as well as prolonged when they have to start dialysis, reduction in the progression of their renal disease and ultimately receiving dialysis. So I put up two studies here. The bottom one is the effects of metabolic acidosis in CKD, and it looked at a meta-analysis that looked at what studies were currently available. And to be honest, this was back in 2017, 2018. The data was not that great. So even though this is kind of a common practice, it was really loaded like moderate quality evidence that was suggesting that we should use this. The more, and you can kind of call it robust, the more robust study that I was able to find in this was done in 2018, published in 2019. And it was called the Uvi Study. So it's a multi-center international study where they looked at either giving oral bicarb specifically to patients or doing quote-unquote standard therapy, which was not a bicarb titrated role. So there are some flaws to this as well. It's open label. There's some variations of practice amongst other people. Some people were still given bicarb in the control group, but it just wasn't a protocol-based specific to target an ideal sodium or an ideal bicarb level as a goal for treatment. So it's like a targeted treatment therapy. And they did show that reduction in mortality, overall mortality during the course of the study, which was I think a little over about a year, as well as a decrease in the progression of CKD over time. And so, here I have the graph that looked at just specifically the progression to CKD. So this was the doubling of the creatinine for those patients during the time period, which was 3 years. And there was a number needed to treat, really only about 7, for patients to reduce their progression of CKD by giving oral bicarb therapy in this targeted time frame. Right? So this is why people are giving bicarb in CKD. This is why it's kind of part of the standard care management of the outpatient practice. And this is why our patient was probably on it, and likely an underlying etiology of what's going on. So why should I consider a bicarb infusion, right? What is the actual data that's out there that we can talk about starting a bicarb infusion for this person is good. So on my literature search for this, there's actually a Cochrane Library study that looked at this specifically with sodium bicarb supplements for treating acute kidney injury. And I'll save you the main summary of this, which was there are no studies. So they did a decently robust review, which oftentimes happens with some of these Cochrane reviews, right? We have a question in medicine. We take a look at the literature. Sometimes, and I appreciate them for publishing this, we come up with the conclusion that we just don't have any evidence. So we can't really make any specific statements as to whether this is done or not. So this is kind of the reality. Looking at our patient, is there any specific evidence that says we should be using this bicarb drip for this person? The answer I can tell you is no. But that doesn't mean that it's not there, right? This is kind of one of the caveats of evidence-based medicine that we talked about. Is just because there's a lack of evidence doesn't mean that there's no evidence it doesn't work. So it just means we don't have studies and we don't have information on it. But I'll talk to you about maybe why we should. So before we get back to our patient, there is only really one main study that I do want to spend a little bit of time on. I think it'll be useful for us to understand. And you may have people talk about it in terms of talking about indications, and that's the Bicarb ICU study. So it's a larger study that looked at the infusion of bicarb for metabolic acidosis in severe and critically ill patients. It was done in France, throughout France, sponsored by the French government. It had a pretty robust study, but it obviously has its own downsides, which we'll talk through. This does not specifically apply to this patient, and I'll tell you why, because this patient would have been specifically excluded in this. And also, these patients were significantly more sick. They were 80% intubated, 80% were on vasopressors. They had a mortality overall of almost 45%, significantly higher. And mortality in patients with renal failure was up to like almost 60%. So this is incredibly sicker patients, even though the average pH level for these patients was about 7.15. But things we don't know, right? They're obviously ventilated. They're having a respiratory compensation. Sometimes we're forcing them a more respiratory compensation for these sick patients as well. And a lot of them were in shock. So just to kind of summarize the Bicarb ICU study, and there's some important things that I think a lot of people don't necessarily know that this study, we probably wouldn't even apply this in our institution. And so obviously these are the inclusion criteria. I'm not going to go through the details, but you need to be acidemic. You also need to be sick, so you need to have a SOFA score greater than or equal to 4. And then they also included a lactic acidosis as one of the inclusion criteria. Things that were excluded. So if you had a primary respiratory acidosis, they didn't really specify if you had a component of respiratory acidosis, did they exclude you? But that was obviously not included. If you have, and this is kind of where our patient comes in, CKD4, you weren't included. If you had GI losses or specific renal bicarb loss, they didn't include you. And the reason why? Because most people would say you should give bicarb to those people, right? So that's what I was talking about a little bit earlier. They did not include primary ketoacidosis, specifically probably likely DKA. And if you were already, for some reason, being given bicarb, you weren't included in the study, obviously. So they did a treatment to try to increase the pH to about 7.3. And at that point, once you reach that goal, the drip was titrated down and until either you left the ICU or your pH in your acidosis resolved. But there's one important thing about this that if anybody talks about starting a bicarb drip, does anyone know what the actual bicarb drip that we use at our institutions when someone tells you put someone on a bicarb drip? You can just raise your hand. Do you know what the concentration is? Okay. So the concentration of the bicarb drip that we typically made at our institutions, you might hear, is 3 amps of bicarb and D5 tonic, a liter of D5 tonic. And so when you order from pharmacy, that's usually what's happening. That's actually a 1.2% sodium bicarb solution. And so that is a third, almost a quarter of the actual concentration that they're using, which is 4.2% in this study. In most ICUs, if they're using a bicarb drip for whatever etiology or reason that they're using it, that's the concentration they're using, right? We know volume can be a problem. And this patient who doesn't make significant amount of urine, volume can be an issue. That's just something I want you to think about to get from this study is that, when we talk about bicarb drip, we may not necessarily be utilizing the best one because there could be a lot of extra volume associated with delivering just the standard solution that we use here. So that's kind of the setup of the Bipartisan trial. So what did they find? So the primary outcome that they looked at was a composite outcome, which is obviously something that I don't really appreciate either. It just means that you went into the study saying you probably couldn't reach a specific outcome, so you tried to compare or combine some outcomes to reach a statistically significant outcome. But theirs was not statistically significant. Their combined outcome was all-cause mortality at 28 days, and it also included one organ failure into that composite outcome as well. So on the slide on the left, the all patients, they compared the bicarbonate treatment group to the control group, and their cutoff that they set for their alpha was 0.05. And they specifically said, for these groups, all patients, the primary outcome was not met. They did have an a priori, or meaning they said, before I started this study, I do want to look at patients who have acute renal failure and what is their outcome. And so for that composite outcome, there was a statistically significant difference and showed that there was a less mortality in the groups who received bicarbonate. So, there is issues, and I do want to mention this as well too. Anytime we're doing multiple sub-analysis, so the study is designed for the primary outcome. It's not designed for the secondary outcomes. So, should we really take information from the study that's based on secondary outcomes? I think that that's just a flaw in our design, especially in critical care studies, that we're looking at the wrong thing. We should look at the thing that we're actually interested in and we know might make a difference based on current knowledge that's out there. And I don't think they did that appropriately with the study. They used it as a secondary outcome, a secondary analysis, which impacts whether you are actually achieving statistical significance or not by the multiple analyses. So just something to keep in mind. So how did they define AKI? Just to know, it's they used AKIN. There's 3 out there that are used in the literature: Reitel, AKIN, and KDIGO. KDIGO and AKIN are pretty similar, but it's most patients who are in the acute kidney injury were in stage 2 and stage 3. So you had to have a pretty significant increase in creatinine or a significant reduction in your urine output, but that's measured over time. And one of the other things that I want to mention about this is that sometimes our understanding whether this person, especially when we think about our patient, whether this person is an AKI or is this just progression in his renal failure. We don't really know that at that one spot in time in the ER. It's hard to make that assessment. We might know it a little bit later, 24 hours later, if we can monitor the urine output, see how it changes with diuretics, see what happens to the creatinine over time after getting a little bit of fluid resuscitation, any changes, and we see what occurs. Maybe there is an AKI component to our patient. And so just to kind of summarize this whole too, this is the 28-day mortalities that they looked at specifically. So the only subgroup that showed statistical significance for the benefit of bicarbonate therapy were the patients with the kidney injury level 2. All the rest did not achieve specific significance, but kind of trended towards that. And then lastly, some of the other secondary outcomes that they looked at were the rates of renal replacement therapy in the bicarb group versus the control group. And so one thing that I think this study does know, it means that we need to do more further research into, is that the rates of renal replacement therapy were significantly less in the patients who were in the bicarbonate group versus the control group. And if you look at the absolute risk reduction, the NNT for this is 4.5. So, right, these are potentially very important things that could change morbidity, mortality, and outcomes for these patients. One of the other ones that's a really patient-centered outcome is dependence on dialysis at the time that they leave ICU. And so these are the absolute rates for patients who have renal failure that went in. 48% of the patients with renal failure in the control group left the ICU with dialysis. 20% in the bicarb group left on dialysis. So a significant reduction in the number of patients that are requiring dialysis who receive the bicarb treatments. So obviously that's one study. And we can't base our information on treatments on one study. And as I told you, that one specific study doesn't directly apply to our patient. But there is no specific studies that apply to our patient. So my argument in saying that maybe this patient should consider a bicarb drip for this infusion is we don't know if this patient is going to resolve some renal function or not. We're told that this patient might actually be making some urine, maybe some mild resuscitated fluids that were given initially some treatment of the acidosis, the primary acidosis, which is, as we assume in this case, is uremic acidosis, likely a predominantly non-anionic acidosis. Bicarb is an appropriate therapy. And so when we monitor this patient overnight, see tomorrow, maybe the renal function improves because we prevented this patient from being on dialysis. Rather than just calling renal right away, putting in a Shiley, starting the ultimate dialysis in a manner that we know is always difficult. Starting dialysis in a more emergent setting usually comes with worse outcomes. Patient's not appropriately prepared, there's no fistula, has to leave with a permacap, all of these other things that we can think about that we might not be thinking about right away. So that's kind of where I wanted to make our point, that this patient, we should consider bicarb infusion. There might actually be a different outcome. So obviously, renal failure is associated with high morbidity and mortality. Patients with CKD are typically on oral bicarb to reduce the function, and maybe this guy is just out of it. And if we put him back on it, his mental status improves, his acidosis will improve, and he's making enough urine to stave off dialysis for now. However, obviously, there's very limited studies out there. That's what makes this a little bit more controversial. We have not looked at these specific things. And so further research is absolutely indicated to determine whether this is appropriate or not. But I would argue I think it is. And for that, I have my references. And if there's any questions on my argument, my side, feel free to go ahead.
Maybe I missed it. You were focusing more on bicarb infusion, not bolus. Any reason that that was why?
So that was the specific question. So the question that they had for the Controversies group was this patient with this uremic acidosis. We assume that the hyperkalemia is and your request is to start an infusion. So one thing that is important, because I didn't have enough time to go into the details of this, and I think Senator can probably speak to this as much as well. Hypertonic bicarb or bolus bicarb has a lot of different effects. It can cause cerebral acidosis, it can cause significant fluid shifts as well, and slower infusion of a lower concentration bicarb might actually achieve the things that you're trying to achieve, which is improving the acidosis over time without significant fluid shifts, as well as it can actually improve the hyperkalemia, but bolus bicarb doesn't unless you lose some of it.
Go ahead, Doctor.
Just two questions. One is if you're using a bicarb drip and you decide you have to use calcium, like to treat hyperkalemia or if they're hypocalcemic, make sure you don't inject calcium into that bicarb while it's infusing, or you'll get chalk, you'll get lime water on the line, and I've seen that happen. The second one is that a lot of these patients are fluid overloaded, and bicarb does have sodium there. So you have to be very careful that you don't hyper fluid overload them, and then you're really in trouble. And then you have to dialyze to get rid of the fluid and the sodium.
Absolutely, yeah. And that, I didn't go into the details of the bad sides of it as well. I mean, treatment of long-term therapy oral bicarb is associated with the adverse events that people look at is rates of hypertension because of fluid overload, because of the salt load that you're giving them, as well as rates of hypertension and fluid overload is primarily what we're looking at. And that's one of the issues with the hypertonic one as well, too.
We're gonna actually move to the con, and then we'll do a discussion panel. I just want to give Surya some time too. Sorry, we'll get time for you, Dr. Sooner, I promise. Okay, we're just going to discuss the opposite side of that discussion about the against side, right? Yeah. Okay. Good morning, everyone. Like Sylvia, I'm just going to present the case against bicarbonate infusion for renal failure. So just to quickly recap the case, the most pertinent parts of it. We have a 55-year-old male with chronic medical conditions that predisposed him to CKD stage 4, coming in with generalized weakness and nausea for 5 days. We don't have any evidence that he's losing any volume that would suggest that he's fluid down right now from baseline. He tells you that he's still making urine, but severely reduced from baseline. You can't quantify how much. You can make the assumption that he's oligodenuric, which means that he probably makes less than 100 cc's in 24 hours. He's hypertensive, he's tachypnic, he's arousable but somnolent. He doesn't have any EKG changes, and right now he's not overtly fluid overloaded, but he has the propensity to become fluid overloaded given he's not making much urine. His labs show, as you know already, 7.1 pH, bicarb 11, potassium 6.3, PCO2 is 30, and his creatinine is 9, which is between 2 to 3 times greater than his baseline, which was 6 months ago. One thing to point out, with a bicarb of 11, his expected compensation, PCO2 compensation should be 23 to 27. And because of this, we see he's 30. We don't know right now if he's already becoming tired from the compensation. So that's very important to keep in mind for later when we talk about the downsides to the bicarb infusion. So when Renal tells you to get him ready for dialysis and start the drip, you're probably gonna think this at first. I know that I have before when I was in the ED, or something like this, or this. But really, it's important. So it's really important to think about why you would even want to start a drip on this patient to begin with. So basically, this patient has hyperkalemia, but he doesn't have any EKG changes. So not really the reason we need to start it in this patient. As well, this patient, we know he has a pH of 7.1. There was a study that showed essentially the rate or the range of pH that's beyond which there's cardiac compromise is below 7.1, which is probably the reason a lot of intensivists use the cutoff below 7 as a reason to be more likely to start the drip. As well, in this patient, it's very important, as Dr. Conrad already pointed out, that this patient likely, at this point from 6 months ago, he already has greater than 25% reduction in his GFR from his baseline. And in my opinion, and from what we see here, it's really hard to tell right now if he even has a component of AKI or if this is just progressive CKD. And at this point, we're not making the argument, or Renal even is not making the argument that we need to prevent the dialysis at this point. The question is, in this patient, will starting the drip now cause more harm, or will it cause any benefit in the time before we start dialysis? Here again, you can see after a certain point, there's no reversibility of the kidney, and at a certain point, you've lost too much function for it to be reversible. Like I said, only time will tell in this patient, but we know right now, based on the way he's presenting, that he likely needs dialysis. He's uremic, he's acidotic, he's hyperkalemic, and he even has mental status changes. And at this point, we don't know what his respiratory status is gonna be like in 20 minutes even. He's already somnolent. Will this patient need bypass? Will this patient need to be intubated? To delay dialysis at this point, we don't know what's gonna happen in this patient. Again, these are the systematic reviews that are, can I prevent this from going forward?
It shouldn't be automatically. Let me see.
We know that the systematic reviews out there, one in 2012, did not show anything at all, essentially, on this topic of interest. But the one in 2009 did point out the only randomized controlled trial that does show any potential benefit at all. But it's very important to point out, like Dr. Conrad said, this does not apply to our patient with CKD stage 4. And looking at it in a little bit of a different view, this paper really discusses ICU critically ill patients with sepsis and septic shock, and essentially the association of improving mortality and decreasing time or preventing immediate renal replacement therapy is not surprising in a patient that doesn't have underlying chronic kidney disease and essentially just has a reversible acute kidney injury. And a lot of these patients, basically, they're all a completely different cohort of patients. These patients have AKA likely secondary to hypovolemia in the setting of sepsis and septic shock. Another important point in this study, a lot of the side effects that were shown, metabolic alkalosis, hyponatremia, and hypocalcemia, were all studied in a different cohort of patients than our patient. And our patient, we don't know in a patient with chronic kidney disease, there are no studies that show in the timeline in a patient that needs dialysis, will a bicarbonate drip help at all, prevent mortality, and in the future as well after dialysis. As well, it's important to point out that this study was underpowered just slightly due to the underestimation of the number of patients needed for the trial. There is a meta-analysis published by Storrs et al. That showed delayed nephrology consultation is associated with high mortality on acute kidney injury. This is kind of an interesting study because it goes through that it's very important to have a dynamic discussion early between the nephrologist, intensivist, and other members of the team. So let's jump into.
Is it doing it again?
Let's jump into, yeah. So there's no studies that definitively. Let me just use that. So yeah, there's no studies that definitively show mortality from a sodium bicarbonate infusion, which is important to point out, but there are a lot of side effects that have been studied and reported in the literature. Two studies, one by Adeva Andani et al., and another one by
Right out. That's the way.
Take it out and present it.
Okay, so like I mentioned, there's no studies that definitively link a sodium bicarb infusion to death, but the side effects have been reported, which have the potential to be severe. Two studies that are listed here for your reference, Adeva Andani and Prout, both studied the side effects of sodium bicarbonate therapy. The most common reported side effects in the literature are ionized hypocalcemia, prolongation of the QTc interval, and as Dr. Gernsheimer mentioned, when you infuse bicarbonate with calcium, that's the potential to have side effects. And in a patient, if a patient is already slightly hypocalcemic, you infuse sodium bicarbonate and you need to correct the hypocalcemia, you have the potential to cause issues. Other side effects, hypercapnia, hypodynamic instability during hemodialysis, hypernatremia, hyperosmolality, potential progression of vascular calcifications, impairment of tissue oxygenation, intracellular acidosis, paradoxical CSF acidosis, and increased lactate production, as well as a slight blood pressure reduction, which is unlikely to be an issue in our patient because he's already hypertensive.
Sorry guys, give us 1 second here.
And I have a slide that actually goes through as well as Dr. Right, so this kind of goes through a little bit more. Dr. Conrad was mentioning that the different types of drips, there's a continuum, and each one has the potential to cause side effects. So at the expense of one effect, you can cause side effects. So with the hypertonic drips, there's a limited effect on the decrease in potassium, but it also has the potential to cause increased intracranial pressure. There have been no studies in humans that show infusion of sodium bicarbonate rapidly causes a increased intracranial pressure, but there are studies in rat models that show that there is a potential to cause that issue.
it infuse rapidly, which is reversed completely when you slow the rate. For the isotonic drip, it has the potential to cause volume overload, and in our patient that is already at risk of becoming volume overloaded, and with decreased urine, likely less than 100 cc's in the last 24 hours, and also has diabetes, which a lot of the bases of the isotonic drips are in D5W. That's also a potential complication and would cause problems. So the question is, in a patient that you know is going to need dialysis anyway, has the potential to become fluid overloaded, has a tenuous respiratory status at this time, will a sodium bicarbonate infusion do anything at all to improve the patient's mortality? As we've said, there are no studies that looking at our specific patient and limited in patients with AKI. But given that you know some of the side effects at this point, we're going to go through some of the most likely or possible clinical sequelae of putting a patient like ours on a sodium bicarbonate infusion. One, volume overload in a patient at risk of fluid overload. As I mentioned before, the risk of alkali therapy in patients with CKD have the potential to cause fluid overload. As well, for bicarb to adequately raise pH, a patient must be able to blow off the generated CO2. This induces hypercapnia. But if ventilation is inadequate to start, and the patient can't keep up with removing the CO2, it has the potential to worsen acidosis. We really don't know. This is all, we don't know how this patient will do, but it's a possibility. As well, bicarb has been shown to cause a possible CSF acidemia, which is still not one of the most, it's still being tested essentially, but it has the potential to possibly cause neurological deterioration, and the reference is below by Soares et al. Published in 2017. As we've already mentioned, bicarbonate, depending on the tonicity, has the potential to cause hypernatremia. In a patient that's oligoinert like ours, making limited urine, already has impaired sodium excretion, we're exposing him to a high sodium load, he or she. And as well, it's also important to keep in mind the starting sodium. If a patient is hyponatremic to start, and we're exposing them to a high sodium load, there's possibility of causing osmotic demyelination syndrome. So the bottom line of all of this, essentially, it can be used judiciously on a case-by-case basis, keeping in mind the risks. Like I said before, there's no studies definitively showing mortality from sodium bicarbonate infusion, but there are reported side effects. And we need more studies that are sufficiently well-powered to show benefit in this specific patient population. As well, there's no definitive studies on the length of time that bicarbonate infusion should be used, and there's no definitive studies on the tonicity and concentration of the drip. And more studies need to be done on this. So if you use a bicarbonate drip, you must know why you're starting the drip and carefully weigh the risks and the benefits. Is it to delay or prevent starting renal replacement therapy in a patient with clear-cut acute renal failure that you have the propensity to possibly not start him on dialysis? If you have a patient that you know is going to need dialysis, then you start thinking, what am I even doing? Am I putting a Band-Aid on the underlying problem, or is this going to help the patient? Since the benefits aren't clear-cut, we have to be willing to ask ourselves, do we want to make a patient worse potentially given the unclear side effects? And at the end of the day, we want to do no harm and address the underlying problem. I'd like to thank Dr. D'Souza, Dr. Kim, Dr. Benabas, Dr. Ahmad, and Dr. Conrad. And here are my references. Thank you for your attention.
Thank you. Thank you for dealing with the technical difficulties. We're going to open this up to a panel. Dr. Sinner, it's all you.
So the first thing is the case.
Yeah.
So I think we anchored too much that this is chronic renal failure going on to worsening chronic renal failure. So I think anyone, especially a male or anyone who has renal failure that is new, you should look for causes of renal failure that we could fix in the ED, like obstruction. So in a male, BPH or prostate cancer, we should look at the bladder, and if the bladder is distended, we put a Foley in and we treat their renal failure, and you don't have to worry about bicarbonate drip. In women, especially older women, you have to worry about retroperitoneal fibrosis, and they need nephrostomy tubes. And they should get them quickly because these are reversible causes of renal failure. Second thing is altered mental status in patients with renal failure. So I think you could anchor, like progression of chronic renal failure, you could anchor to say that this is just uremic encephalopathy. I think that's a diagnosis of exclusion. And I've seen many, many times that patients are signed out to me, well, this patient's mental status is worse just because his BUN is 100. And I say, well, did you get the CAT scan? And then he has bilateral subdurals, which is very common in dialysis patients because they play with dysfunction, they hit their head. So mental status changes in patients with renal failure should never be assumed to be uremic encephalopathy without ruling out other things. So I think that those two things in this case, hopefully we have worked out before, and also other causes of acidosis like aspirin ingestion and all the other mud piles things that we should think about before we just say this acidosis is from chronic renal insufficiency or uremia. Most patients who progress from chronic renal failure to now dealing with dialysis they have like a renal tubular acidosis. They can't produce enough bicarbonate, and most of those patients who start on the day of their first dialysis, if you look at their anion gaps, it's a non-anion gap acidosis. Acute renal failure, we always say, is a anion gap acidosis, but in patients who progress to chronic renal failure, on the first day of dialysis, the most common is a non-anion gap because they can't make new bicarbonate. So in those patients, as Conrad said, you should give bicarbonate to because they're going to need bicarbonate for the rest of their life, and you could just give them PO. To the question of giving them a bicarbonate drip to prevent dialysis, first of all, there's no mechanism that I could think of that bicarbonate prevents progression of renal failure. There's just no mechanism. It doesn't work like that way. People are, if you look at the timeline to start dialysis, well, because people do dialysis, more likely to do dialysis in acidemic patients. So if you give them bicarbonate, it decreases the time to dialysis, but it's just because it's a number game, not because you've affected anything. And then the last point is that we give bicarbonate at doses, the drips that we give, as Conrad said, are under-concentrated compared to other people's. We give like 2 or 3 amps and a liter of D5, and we give it at 42 cc's an hour. So in the world of nephrologists, this is like pissing into the ocean. So this is not going to change the bicarbonate at all. So if the renal people say, give them a bicarbonate drip, I just say, okay, because it's not going to do any harm, it's not going to do any good. It's like doing urinalysis on stroke patients. You really want this so I can admit the patient? And it saves me an argument, and I don't really have to talk to them, which I would prefer not to. They're certainly not going to understand the literature that I know. So I'm just not going to talk to them. So you want the bicarbonate drip? Sure, 42 cc's an hour. The risk of giving a lot of bicarbonate, I think, is also is too much, because when we dialyze the patient, we dialyze them against bicarbonate bath. They get a massive dose of bicarbonate, like the first 2 hours of dialysis. Because whatever their bicarbonate is, the dialysis corrects it in 2 hours. The bicarbonates, so they get a massive dose of bicarbonate, and it's okay. So kind of my view of this is, the renal fellow, because he read somewhere in the Washington manual, you should give bicarbonate drips to people who are acidemic. Okay, do it. It's not going to really hurt the patient. It's not going to really harm the patient. Just do it. If they really want it, you want to save an argument, there's no data to show that there's a benefit. There's no data in the one paper that both of you got was the only RCT ever on bicarbonate in very acidemic patients. It didn't work at all to change mortality. So those patients are much sicker than the regular dialysis patient. So I always ask, why are we giving this bicarbonate drip? And then I get from the renal fellow mostly, my attending wants to do it. And they certainly have no idea why they're doing it. And then I say, okay, can I admit the patient now? Are they upstairs? So I think that it's a little effect. It's not a bad effect. There's no benefit to the effect. If you want to do it, do it.
Any other attendees? Input? Any questions? Okay, all right. Any questions on Zoom?
I had a question and hello?
Yeah, we can hear you.
Oh, okay, great. So I had a question. So basically, like what Dr. Snert was saying, that giving bicarb is basically harmless because in that concentration that we give it, it basically doesn't do anything. But given that we know it doesn't do anything, is it appropriate to do it like because their kind of argument to give it the bicarb is that it would delay the hemodialysis? So let's say it's midnight and they're like, okay, just put the patient on bicarb drip and we will come in the morning to dialyze the patient, which was basically what our case was. Is that appropriate or not? Yes, it doesn't do any harm, but also isn't it delaying getting the patient the dialysis that eventually they need? And I also wanted to make a...
dialysis. This is just, they're going to delay the dialysis. They're just giving you a reason that makes them feel better about it. But whether you give the bicarbonate or not, they're still going to, if they're going to delay the dialysis, they're going to delay the dialysis.
Did you hear that, Roshna?
Yes.
Any other questions?
Hold on, just one more thing about that. In the Bicar ICU trial, the patients that were randomized to bicarbonate had a lower proportion of patients who ended up needing dialysis, as well as longer time to needing dialysis as well. So there is some evidence that doing a bicarb drip may be helpful in some of these patients, especially the ones with severe AKI and acidosis. But again, this was the only trial to show that sort of benefit. So outside of the Bicar ICU trial, again, there isn't much evidence for it, but there is some evidence to support it. If I kind of agree with Dr. Sinnert in that it'll save you an argument if you just do it. There isn't really much harm to it, especially, again, at the ranges that they're asking for. But there is some potential benefit for it.
Well, then the argument is needing versus giving, right? So
Right.
maybe it had nothing to do with, how do you decide when you need dialysis? You decide when the machine is available and the nurse is available.
Was one of the indications acidosis? That you
No.
just fixing the acidosis?
No.
That's one of the ones they put the renal team said.
Yeah, but you're just changing the number.
Right,
So they
exactly.
can delay it, but you're not changing the patient's course.
Exactly.
So this is just a number game for them. This is just a reason for them to delay the dialysis.
One thing I would want to add to kind of go off of what he said. So I agree with Dr. Sinnert that the concept of giving bicarbonate and this dialysis, there's no specific mechanism for that. But my main qualm with the Bicar ICU is that some of the other faults that were already discussed about it is that, I think a lot of the research that we do in that critical care is focusing on mortality. So what is the primary outcome is probably the wrong thing to do. We're looking, these patients have incredibly high mortality. There's probably very little we do that actually changes the ultimate outcome. But there may be some specific things that we appropriately design our studies to say, maybe we are just treating a number, but treating that number means that person is not on dialysis right now, and utilizing their resources less at the moment can be beneficial and useful. I mean, we know that we run out of resources. We run out of resources here a lot. And I think that that's just one of the things that we should think about, that maybe mortality is not the only answer that we should.
There is one reason to give bicarbonate to hyperkalemic patients that you guys didn't cover.
Yeah.
Is that below pHs of 7.2, a guy named Kim in the 1990s in South Korea did some really nice experiments to show that below 7.2, if you give insulin and just give insulin, their potassium drops about 1.
But if you give insulin with bicarbonate, when the pH is less than 7.2, it drops 1.5. So there's a synergistic effect. If you just give bicarbonate to patients who are hyperkalemic, the K goes up. Never do that. But if you give, and he did the same experiment with beta agonists. If you give a beta agonist with bicarbonate, the K drops a little bit faster and a little bit further. And it's because the cell surface binding of beta agonists and insulin is improved when the pH is above 7.2. So there's this theoretical benefit in hyperkalemic patients, but the benefit is very small. It's 0.5. And no one's ever saved anyone's life about a change in K of 0.5, right? So, the K drops 1 to 1.5, that's good. But, so there's a theoretical benefit in severely acidotic patients with hyperkalemia to give some bicarbonate, but just a little bit. And that's IV push, non-drip. Yeah.
Okay, great. Let's take a few minutes break and we'll get to our EMCCM. Thank you guys for the debate. Sorry for the technical difficulties.